Bismillah ar-Rahman ar-Rahim. Our talk today will be about thyroid gland. We are going to introduce thyroid gland to dentistry students. This will comprise anatomy, physiology, and investigations. First, we are going to start with anatomy, and these are the items we are going to tackle. The anatomical side, the blood supply, the venous drainage, the lymphatic drainage, important structures related to the gland. These are two tubes, two nerves, two large vessels. To start, the thyroid gland, as all of you know, is a butterfly-shaped gland present in the lower part of the front of the neck, overriding the trachea and abutting the carotid sheaths laterally. It has its blood supply, the arterial supply, from the superior thyroid artery arising from the external carotid artery and from the inferior thyroid artery arising from the thyrocervical trunk first part subclavian. On the right side of the screen, we can see its venous drainage, where the superior thyroid vein goes to the internal jugular vein. The middle thyroid vein, if present, goes to the internal jugular vein as well. And the inferior thyroid veins from both sides, from both lobes, go to the left innominate vein. This is a more complicated photo where we can find the carotid sheath here. Behind this carotid sheath is the vagus nerve, the 10th cranial nerve, from which arises the recurrent laryngeal nerve. This recurrent laryngeal nerve, this is the vagus nerve, as you can see here, but here we are in the vicinity of the chest. Here is the recurrent laryngeal nerve because it recurs back all this distance to enter the larynx at this area. On the right side, it winds around the subclavian artery, but on the left side, it winds around the aortic arch itself and goes back to the neck, running in the tracheoesophageal groove on both sides to enter the larynx at this level, which is the level of the cricothyroid muscle or the inferior constrictors of the pharynx. This recurrent laryngeal nerve is called recurrent because it recurs in its course, as we have seen. Is also called inferior laryngeal nerve, and this is a mixed nerve, both sensory and motor, supplying sensation to the interior of the larynx from the level of the vocal folds downwards, and as a motor supply for all the intrinsic laryngeal muscles except the cricothyroid, which is supplied by the external laryngeal nerve. The external laryngeal nerve is a nerve arising as well from the vagus as a branch from the superior laryngeal nerve. Then the vagus gives superior laryngeal nerve. The superior laryngeal nerve gives internal laryngeal nerve, which is sensory, and external laryngeal nerve, which passes here and is motor. So both branches, the internal and the external branches of the superior, both are corresponding to the inferior laryngeal nerve, which is called also the recurrent laryngeal nerve, and this recurrent laryngeal nerve is both sensory and motor. The lymphatic drainage of the neck is divided into areas, where area 1 comprises the submental as 1A, submandibular as 1B, then the deep jugular veins, the deep jugular lymph nodes, the lymph nodes which are contained within the carotid sheath along the whole of the neck, along the whole length of the neck. These are divided into groups 2, 3, and 4, as you can see. Group 2 extends from the skull base to the level of the hyoid bone, 3 from the hyoid bone to the cricoid cartilage, and 4 from the cricoid cartilage to the suprasternal notch or to the clavicle. Then all lymph nodes posterior to these groups, which are present in the posterior triangle, are called level 5, while lymph nodes present anterior to these groups are known as level 6, which are present in the visceral compartment. This is bounded by the hyoid bone above, the suprasternal notch below, the anterior border of sternomastoid posteriorly, and the midline, the imaginary midline of the neck anteriorly. Also, there is area 7, which is present here in the superior mediastinum. It is not an area of the neck, but it's always included within the neck nodes because the midline organs, such as the thyroid and the larynx, give their sentinel lymph nodes or first echelon lymph nodes as level 6 and 7. For the thyroid gland, we have the lymphatic drainage going to level 6 and 7 as the first echelon. Then they do not follow the numerical order, but they follow another order, which is in most of the cases is level 3, then 4, then 5, then 2, then 1. So level 1 lymph nodes are the least to be affected in cases of thyroid cancer. These are the points we have tackled now. We have also spoken about the two large vessels, which are the intenojugular vein and the carotid sheath, present in the carotid sheath, just lateral to the thyroid lobe. The two nerves we have talked about, which are the recurrent laryngeal nerve and the superior laryngeal nerve, while the two tubes are the esophagus and the trachea. As we said, the thyroid gland resides over the trachea and is also related to the pharynx and the esophagus, which pass behind the trachea, deep to the trachea. Then we have the section of congenital anomalies. The first congenital anomaly is agenesis, where the baby is born without a thyroid gland. Lingual thyroid, this entails that the thyroid gland, which originally forms in the area which will be in the future called foramen cecum, that is the junction between the anterior 2/3 of the tongue and the posterior third. There, in the embryological life, the thyroid gland forms. Then it descends downwards, migrates downwards through a duct known as the thyroglossal duct to reside finally in the final destination in the lower part of the front of the neck. Sometimes this migratory process fails to occur and the thyroid remains in the foramen cecum or in the junction between the anterior 2/3 of the tongue and the posterior third of the tongue, and the baby is born with this lingual thyroid, which presents as a rounded swelling that may be the only thyroid tissue present in his body. It may cause dysphagia, interference with speech, or even crying, respiratory obstruction, or hemorrhage. It looks like this, and it should be treated by excision. But if ultrasound proves that the baby has no thyroid gland in its original position, then the patient, after excision of this tissue, which is in such a case is the only thyroid tissue, then the patient should be replaced with eltroxin. Otherwise, he will suffer from hypothyroidism, and in the such young age, hypothyroidism is very, very dangerous because it might result into mental and physical retardation. So we do an ultrasound in such a case. If the thyroid gland is present and the lingual thyroid represents only a partial failure of the migratory process, then it can be excised safely without replacement. But if the baby has only the lingual thyroid as his thyroid tissue, then after excision, the baby should be replaced. The third thing is the median ectopic thyroid tissue, where the baby might have part of his thyroid gland present in the midline of the neck because of partial failure of the migratory process as well. In the past, there was a term known as lateral aberrant tissue or lateral ectopic thyroid tissue, but now this is obsolete and it's not considered a congenital anomaly, but it is considered metastasis from an occult papillary thyroid carcinoma. The fifth congenital anomaly is thyroglossal duct cyst, which means that during the migratory process, after the migration is full, after the migration of the thyroid gland from the foramen cecum to the lower part of the front of the neck has been completed, then the thyroglossal duct that was originally created for migration of the thyroid gland now loses its function, and so it should disappear, and it obliterates from above and obliterates from below until it's completely obliterated and disappears. Sometimes this obliteration process fails in the middle part, and so it obliterates from below and obliterates from the above, but in the middle part it does not obliterate, resulting into a cyst known as thyroglossal cyst, which is a very famous congenital anomaly where the baby is born with it. It might be below the hyoid bone, it might be in the region of the thyroid cartilage, above a little bit or below a little bit. It moves characteristically with protrusion of the tongue. Of course, it moves with deglutition as the thyroid gland does, but it is characterized by its mobility with tongue protrusion. Its treatment is excision with the middle part of the hyoid bone in an operation called cyst trunk operation, where we excise the cyst, the part of the cyst that connects the part of the duct that connects this cyst to the central part of the hyoid bone, and the remnant of the tract going up to the foramen cecum. This whole part should be excised on toto in an operation called cyst trunk operation, so that we guarantee up to 98 or 99% that there is no recurrence in the future. Characteristically, it appears around the age of 7 years, but sometimes it appears later in life, or the patient has been diagnosed by thyroglossal duct cyst in the childhood, but he refuses to do surgery, so he presents as an adult one. Here we can see that the thyroglossal duct that is present in the neck here, we can see it here. Then when it appears, it goes upwards when the tongue is protruded, and goes downwards again when the tongue is back in the mouth. This is another case. This is a very, very large thyroglossal cyst that gives the impression at the first sight that this is a goiter. However, on meticulous examination, by raising the tongue, by protruding the tongue of the patient, we will see that the cyst is moving up and down, up and down. So this is a thyroglossal duct, not a thyroid swelling. If this cyst forms an abscess, it might be drained surgically, or it might result into ruptures, spontaneous rupture, and in both cases, it most probably will result into a thyroglossal duct fistula, where the interior of the cyst will communicate with the skin with a fistula known as thyroglossal fistula. It's never a congenital fistula. It's always acquired due to the process we have said. Infection of the cyst or inadequate removal. It moves as well with protrusion of the tongue, and it's also treated with excision through the cyst trunk operation. This is a picture for a patient having both goiter and thyroglossal duct fistula. This is the picture. This is the photo of the fistula, and it moves upwards with tongue protrusion and downwards with tongue back into the mouth. And as you can see, this patient is an adult one, not a baby. The second section of our lecture is physiology, where physiology, we need to know certain simple facts about the thyroid gland. As dentistry students, we don't have to go into the details, but we have to know that there is what is known as the pituitary gland in the brain. This pituitary gland produces a chemical, a messenger called TSH, thyroid stimulating hormone, that goes into the blood and stimulates the thyroid gland to release T4 and T3. These are two hormones released from the thyroid gland. Then these two hormones go back into the blood and forms what is known as negative feedback on the TSH. So in the normal conditions, the TSH is normal in the blood with the T3 and T4 normal in the blood. This is called an endocrine axis, or feedback mechanism between both glands. Of course, the T4 and T3 go in the bloodstream to the target organs to produce its effects that we will know in a minute. And it goes for negative feedback on the pituitary gland. It also has a negative feedback on the hypothalamus, which is responsible for producing a thyrotropin releasing hormone, or TSH releasing hormone. But we can skip the role of the hypothalamus and concentrate about the orchestra played between the pituitary and the thyroid gland. The thyroid gland produces both T3 and T4 with these differences between both of them. And of course, we have to know that both hormones, when released into the blood, are attached to plasma proteins, so that 99 to 99.5% of these hormones are deactivated, and only half to 1% of the total amount is present in the free form, and this free form, known as free T3 and free T4, are the parts that are responsible for our metabolism. The functions of the thyroid hormones include tissue metabolism, which means increasing appetite, decreasing body weight, increasing heat production by increasing the basal metabolic rate, and increasing oxygen consumption. It also increases the sensitivity of beta adrenergic receptors so that it increases heart rate. It might cause lid lag due to stimulation of the sympathetic part of the muscles of the upper eyelid, known as the Mullerian muscle, and it can affect CNS in the form of tremors when they are more than needed. Also, it might cause nervousness. Tissue growth by secretion of growth hormone that results into growth and maturation of tissues, and that's why if the baby is born with a genetic thyroid gland, he will be known as cretin or congenitally hypothyroid. And this should be diagnosed very, very early, because if the patient lives his first 6 months of his life without enough thyroid hormones in his blood, he will develop mental and physical retardation that are irreversible. We are left now for investigations. Investigations include first the thyroid function tests. This includes estimating the TSH and total and free T3 and T4 in the blood, and also thyroid autoantibodies, which are high in certain autoimmune diseases such as Hashimoto thyroiditis and Graves' disease. This is an example for whenever the patient has a euthyroid state, he has normal thyroid functions, then the TSH is normal, the free T3 and the free T4 are normal in his blood. If the patient is thyrotoxic, meaning that he has very high amounts of thyroid hormones in his blood, then his TSH will be undetectable, his free T3 and free T4 will be high in the blood. If the patient is hypothyroid or developing myxedema, this is the adult form of hypothyroidism, then the TSH will be high and the free T3 and the free T4 will be low. Okay, normally when the free T3 and the free T4 are low, they stimulate this low level in the blood stimulates the pituitary to produce high TSH, which stimulates the thyroid gland to produce normal T3 and T4, and then we go to normal status. But when the gland is diseased, this feedback is not successful, and the patient will develop high TSH with low T3 and T4, which cannot be corrected. Or if the patient is thyrotoxic, then this mechanism is not successful as well, where the TSH remains undetectable and the free T4 and the free T3 are very high. Obviously, this means that if the patient is thyrotoxic, then there is an intrinsic mechanism inside the thyroid gland that makes it produces very high levels of thyroid hormones into the blood and not responding to the message sent to it from the pituitary gland through the low levels of TSH to stop producing. This thyroid gland is now crazy gland. It's not a sane gland. It's not a wise gland. It's not a gland that is responding to the message produced by her father, her mother gland, the pituitary one. The myxedema is a condition that is having as well an intrinsic problem. There is an intrinsic problem in the thyroid gland where the thyroid gland is unable to produce hormones in spite of the high TSH that is sent by the pituitary trying to stimulate it to work more, to produce thyroid hormones more, but the thyroid gland, because it is diseased, sometimes damaged, sometimes removed surgically, is not responding and cannot respond to the high TSH, and so the patient remains euthyroid. Of course, if this patient is thyroidectomized and we give him replacement eltroxin from the outside, as in the form of a pill, then this will result into normal levels of his T3 and T4 in his blood, which after some time will make this high TSH normal TSH, and we regain again the normal mechanism. And the thyroid hormones and the TSH are all normalized in his blood. The second group of investigations is the radioisotope studies. These radioisotope studies means that we do a thyroid scanning. What is its principle? Its principle is that we inject the patient or make the patient ingest some material which is radioactive, and this material we know that it can be absorbed and concentrated by the thyroid gland much more than any other organ in the body, and this is ideally the iodine. But we give him radioactive iodine, and then we image the patient with a gamma camera, resulting into a radioisotope study known as thyroid scanning. And this we can use isotopes like 131, 123, and technetium-99. Just know the names, you don't have to go into its details. If a nodule in the thyroid gland takes radioactive iodine more than the remaining thyroid tissue, then this nodule is known as hot nodule or toxic nodule. If it takes the thyroid, if it takes the radioactive iodine in the same concentration as the remaining thyroid tissue, it's known as warm nodule or normal nodule. If it concentrates radioactive iodine in less fashion than the remaining thyroid tissue, then it's called cold nodule or non-functioning nodule. The importance of thyroid scanning is that in the past we said that cold nodule is 100% malignant. Then this number has reached very low numbers now. So the cold nodule can be many diagnoses, not only cancer. So thyroid scanning to differentiate benign nodules from malignant nodules have lost its function now, and we only do thyroid scanning in very limited cases preoperatively to differentiate between some toxic patients. But it's the thyroid scanning and the whole body scanning by radioactive iodine has its main role now only in the post-operative period after excising a thyroid gland that has been diagnosed by papillary thyroid carcinoma, and the patient has been treated by radioactive iodine as an ablative material. Then we do radioactive iodine whole body scanning to image if the patient has any metastasis in his body or he has been cured. And this will be explained in details in the lecture of the malignant thyroid diseases. So whole body scan for metastasis is the main and most important use of radioisotope studies for the time being. These are pictures for how thyroid scan appears. Radiography includes plain X-ray neck and chest, barium swallow, ultrasound neck, duplex, and CT of the neck. But we have to know that ultrasound neck, these 5 investigations, we mean that we might need these investigations in certain cases. But you have to know and you have to emphasize that ultrasound neck, this one, is very crucial investigation for any thyroid case. So any thyroid case should have a neck ultrasound as an assessment tool. In most of the cases, we do not need any other imaging tool, but sometimes if we need another thing, this other thing might be plain X-ray for the neck and chest, barium swallow, duplex, or CT neck. The biopsy, which is particularly fine needle aspiration taken by a syringe and under ultrasound guidance, is the investigative tool of choice for diagnosing and differentiating thyroid nodules being benign or malignant. The laryngoscopy is some sort of endoscopy to see whether the patient has his vocal cords normally functioning or not. And now we are done with our introduction, and in the next lecture, inshallah, we are going to discuss benign forms of goiter. Thank you very much.